Dear colleagues, I'm very pleased to share with you data from a prospective cohort study around the alterations of sleep and circadian rhythm and suicidal ideation in a very specific sample from a prospective cohort that we are running in France of treatment-resistant depressed patients. First of all, my disclosures, a few works with different companies at boards and also clinical trials in the field of depression and also in the field of schizophrenia. First of all, some context. And we all know as clinicians that major depressive disorder is associated with a high rate of suicidal attempt, and suicide, and it's up to 20% of the patient during the lifespan, which is higher compared to the general population. And for patients suffering from treatment-resistant depression, which is a specific subgroup, up to 30% of patients will attempt suicide with a lifetime suicide rate more than twice of patients with non-resistant depression. So we need to identify specific risk factors and biomarkers to prevent suicide, as well as to identify new therapeutic targets for suicide prevention. A few data about sleep disturbances and suicidal ideation in general and psychiatric population. We know that there's a strong association between sleep and biological rhythm disturbances, and also suicidal ideation and suicidal behaviors, both in general but also in psychiatric population. Insomnia is associated in a meta-analysis conducted in studies in general population, demonstrate that insomnia is associated with suicidal ideation, suicide attempts, and suicide with a 2 to 3-fold increased risk of suicide. And it was interesting that it was independent of the presence of depressive symptoms. Time of wakefulness, of nocturnal wakefulness, is correlated to the risk of suicidal behavior. And the very interesting thing about sleep complaints, in a 3-year prospective study, we have a confirmation that sleep complaints were associated with an increased suicide risk, and it was independent of psychiatric disorders and even of different prior history of suicide attempt, wide range of different characteristics, clinical and socio-demographic characteristics. We know that in depressed patients, we have a specific different aspect with an insomnia complaints with a prevalence of more than 80%, 85% in those patients. And insomnia predicts suicidal ideation independently of depressive symptoms. Nightmares, which is an important point, are very common with a prevalence of up to 90% in depressed patients compared to 5% of the general population. And nightmares are associated with suicidal ideation, suicidal attempts with a 2 to 3-fold increased risk. And it's very interesting to see that 80% of these patients have an alteration of their dreams during the months before the suicidal crisis, with alterations progressing from bad dreams to nightmares and then to suicidal scenarios. In a prospective study, Geoffroy and al. Reported sleep disturbances and suicidal risk with an association between global insomnia and suicide within 1 year. And there's also an association between chronotype and suicide attempts that has been observed, with more occurrence of suicide attempts during evening and more severe suicide attempts in the morning. The asynchrony of circadian rhythm is also associated with suicide. When you will look at treatment-resistant patients, we find only one study using polysomnography to identify specific sleep architecture abnormality in TRD patients, with changes in non-rapid eye movement sleep and nocturnal arousal that were associated with suicidal ideation in those patients. So in this specific population, no study has tried to look prospectively to explore the association between sleep disturbances and disorders and suicidal ideation. So in our cohort of treatment-resistant depressed patients, we decided to conduct a study of a 1-year study to try to describe and characterize sleep disorder or the circadian rhythm disorder and suicidal ideation. So first of all, this study was conducted in a network of what we call treatment-resistant depression expert center, some kind of third-line care centers in university hospital. We have 13 such centers in France coordinated by the Fondation Fondamentale, and I'm coordinating all this network. And we were including successively patients who are clinically unresponsive and considered to be treatment-resistant depression to at least 2 successive courses of antidepressants with 2 different pharmacological classes. MADRS was above 20, and they were considered in terms of using the Taze and Rush classification from treatment-resistant depression, a score more than 2, equal or more than 2. And we exclude all the other kind of depression that we can observe in bipolar patient, in obsessive-compulsive disorder, in psychotic disorder, also in eating disorder or somatoform disorder, or any kind of mood disorder related to substance abuse. To evaluate sleep and circadian rhythm, we use the 19-item Pitsburgh Sleep Quality Index with the French version, and we try to explore and use a subscore: subjective sleep quality, sleep latency, sleep duration, habitual sleep efficiency, sleep disturbance, sleep promoting medication, and daytime function. To define and explore sleepiness, we use the Epworth Sleepiness Scale to have this subjective measure of daytime sleepiness. And we also use a composite scale of morningness to evaluate the chronotype. For suicidal ideation, we use 2 different tools: the interview on suicidal feelings by Pechel, trying to define with fine progressification the severity level of suicidal ideation, but also the Columbia Suicide Severity Rating Scale, which is rather well known. And when we collected a few sociodemographic and clinical parameters, you can see gender, lifetime history of suicide, we try to explore also childhood history of maltreatment using the childhood trauma questionnaire. We try to explore impulsiveness, but also tobacco smoking and anxiety level. So just look at the results. First of all, when we look at the history of suicide, current suicidal ideation and history of suicide more frequent, significantly more frequent in patients that were younger, with more severe depressive symptoms and more childhood trauma, using the childhood trauma questionnaire. And there was differences in terms for current suicidal ideation of history of suicide attempts. We find differences in terms of level of education, the number of lifetime depressive episodes, the level of anxiety, but also impulsivity. When we look at suicidal ideation during the follow-up, when we look at our sample, we included 261 patients, and only 148 can be evaluated at follow-up after 12 months. And on those patients, 8.8% of them answered that they had suicidal ideation during the period of observation, and 15% reported at least one suicide attempt since baseline. Using the different safe ratings and of evaluation of sleep and circadian rhythm in our sample, we can see that 90.9% of patients had poor sleep quality, with very specific poor sleep quality in patients with more depressive symptoms and more childhood trauma. 51.2% of an excessive daytime sleepiness, and that was significantly more important in patients with younger age and with a higher level of impulsivity. And when you look at the chronotype, 31.6% have an eveningness chronotype, which is associated with more frequently younger age and earlier age of onset at MTD. Then we tried to find the association between chronotype, sleep quality, and excessive daytime sleepiness with current suicidal ideation at baseline. You can see that we have a correlation, but when we adjust these different association for age, gender, BMI, depressive symptom severity, childhood trauma, anxiety level, impulsivity, and daily tobacco smoking, we didn't find any association between evening chronotype, sleep quality, and excessive daytime sleepiness and current suicidal ideation at baseline. And when we look at the patient with a severe suicidal ideation using the question 3, 4, 5 on the identification of this evaluation using the PECL tool, we can find no association neither. And when we look at the association between chronotypes, sleep quality, and excessive daytime sleepiness and lifetime suicidal ideation, we neither to find no adjustment. After adjustment, we don't find no association between these different variables, evening chronotype, sleep quality, and excessive daytime sleepiness and lifetime suicidal ideation at baseline. And then when we look at the association between daytime dysfunction and current suicidal ideation in the last week, we don't find any association. Only in severe patients when there's no severe suicidal ideation. And when we look at the association between evening chronotype, PSQI, total score, and suicidal ideation during the one-year follow-up, after association, we don't find any kind of association statistically significant. So when we look at the association between sleep disorder at baseline and the risk of suicidal ideation between baseline and 12 months, then we find that daytime dysfunction at baseline predict suicidal ideation over the one-year follow-up with an odd ratio of 1.81. And the subscore, promoting medication subscore of the PSQI, show that hypnotic intake is associated with a decrease of the risk of suicidal ideation of the one-year follow-up with an odd ratio of 0.73, which is statistically significant. And when we look at sleep and circadian parameters at inclusion and suicidal ideation after 1 year, we find that there's a significant association between excessive daytime sleepiness and suicidal ideation at 1 year follow-up. And even after adjustment for age, gender, BMI, depressive symptom severity, and childhood trauma, but also anxiety level, impulsivity, and current daily tobacco, the association remains significant. And higher daytime sleepiness at inclusion predict suicidal ideation during the year with an odd ratio of 1.077. And excessive daytime sleepiness at inclusion predicts suicidal ideation during the year with an odd ratio of 1.7. Both were significant. So we have seen that there's no real association at baseline, but we can see that the risk of suicidal ideation at 1 year of follow-up is increased with the daytime dysfunction score and the excessive daytime sleepiness score at baseline. But on the other hand, hypnotic intake at baseline predicts this decreased risk of suicidal ideation over the 1 year follow-up. When we look at these results, we can conclude that Our result confirmed the previous finding that daytime sleepiness may be related to the suicidal phenomenon. But we did not replicate the previous observations suggesting an association with poor sleep quality and sleep duration and a suicidal phenotype. So, in our study, neither sleepiness nor suicidal ideation is explained by insomnia or poor sleep quality. But we highlight that sleep disturbances and daytime sleepiness may reflect different processes and may play a clear role in suicidal ideation independently in the population of treatment-resistant depressive patients. And diurnal symptoms of the symptom of sleep disorder are most likely to be involved in suicidal ideation. The hypnotics. In our study, we have described that hypnotic state is associated with a reduced risk of subsequent suicidal ideation after 1 year of follow-up. And it's interesting to see that that can be related to the McCall study published in 2019 of this 8-week double-blind RCT study of an association of zolpidem with SSRI or compared to placebo with SSRI in 103 major depressive disorder patients with insomnia and suicidal ideation. In this study, the result did not support the routine use of hypnotic medication for suicidal ideation in all the depressed patients. And because there's no real on the primary outcome, there's no real adding hypnotic to antidepressant, there's no real advantage in terms of decreasing suicidal ideation. But there's an advantage for hypnotic in the suicidal ideation using the Columbia scale, and that was the second outcome. And what can be inferred is the fact that the co-prescription of an hypnotic during initiation of an antidepressant may be efficient in suicidal patients, and the resolution of suicidal ideation positively covaried with that of insomnia symptoms according to the hypnotic intake, and the impact of hypnotic on suicidal ideation was much greater in the patients with the most important, more severe insomnia. We also conducted a few post-hoc analyses in our population to explore the link between the at 1 year because the hypnotic intake, suicidal ideation, and sleep symptoms. In patients with no suicidal ideation, we have a significantly larger improvement in sleep quality and a significantly larger decrease in sleepiness compared to the patient with suicidal ideation. So it's interesting that it's not exactly the same. And even if it's adjusting for the severity of symptoms, the hypnotics, intake, age, gender, BMI, level of anxiety, impulsivity, childhood trauma questionnaire, and also tobacco smoking. We don't find a real significant difference, but a trend in patients with the suicidal ideation. There's a worsening in the daytime functioning, dysfunction, compared to patients without suicidal ideation. But it was not significant, it was only a trend. We also observed that there's no significant association between the fact of taking hypnotic at baseline and the total score on PSQI, Epworth, and also that hypnotic intake at baseline was not associated with an improvement at 1 year of quality of sleep, daytime function, and or daytime sleepiness. Patients who had suicidal ideation at 1 year have less improvement in the PSQI sleep-promoting medication subscore than patients without suicidal ideation at 1 year, but there's no real statistically significant difference between those two groups. It's only a trend, one more time. And suicidal patients less decrease their hypnotic intake according to the PSQI sleep-promoting medication compared than non-suicidal patients at 1 year. And then it was interesting because it was significant. So in our study, there's an independent link between improved sleep and alertness and decreased suicidal ideation at 1 year. Limitation of our study is the fact that, first of all, we didn't use objective measures like polysomnography. That would be very interesting, but we only use self-reported questionnaire. And the other point is the fact that the sample is rather small according to the occurrence of suicidal ideation and suicide attempts. So we need more patients to have more power. So to conclude, in our study, we demonstrate that in treatment-resistant depression patients, diurnal symptoms of sleepiness and dysfunction are predictors of suicidal ideation, and hypnotics intake is associated with a decreased fear when we have this 1 year observation. That gives an interesting insight to explore the link between suicide and sleep, alertness, and that can have interesting implications for research on suicide mechanism and suicide crisis. And this finding may be important for screening patients with TRD at risk of suicidality using the short excessive sleepiness scale, and try to include the need for targeting diurnal symptoms of sleep disturbances to prevent suicide in these TRD patients, including the way of taking care of them. Thank you for your attention.